I promise I'm going to be much more optimistic today because we've got a great panel, and I'm looking forward to playing the role of a reporter and asking them very deep, thoughtful questions. And I don't have to answer them. So we've spent a lot of time, and I've certainly spent a lot of time talking about the journey to value. And I discussed this a little bit yesterday, when you think about our healthcare system as it currently operates, the system overvalues doing things as opposed to what Elena had mentioned, actually outcomes and improving health and well-being. Our billing system does not reflect a lot of the interventions that primary care physicians provide, primary care clinicians provide in helping manage and navigate patient care through the system. And the exciting thing is that employers are starting to figure that out and really questioning what their premium dollars are going for and having difficult conversations with the insurance industry as well as the healthcare industry about what they expect and what they want for their premium dollars. So we're going to try to dive into all of those questions with our great panelists. So I'm going to ask each of our panelists to spend a couple of minutes and just give some background about themselves, kind of how they think about healthcare and help frame the conversation. So Chris, you're closest to me, so we're going to kick it off with you.
Well, thank you. I'm very glad to be here. I serve a couple of different roles. I am the executive director of the Houston Business Coalition on Health in Houston. We represent approximately 1.8 million employer-sponsored lives around the country, of which 1.1 million are in Texas. We're focused, our mission is focused on cost, quality, and consumer experience, the triple aim, in healthcare delivery. It's been an exciting 10 years for us, and we have found our niche, and I'll get into this more in further discussions, but let me just say that the pinnacle of what we support is the advanced primary care model of delivery, and it's sinking in to employers. My other role is the executive director of a new C4. It's called Texas Employers for Affordable Healthcare, and that is at the state level. And our role is to influence legislation in 2023 to influence, to further develop transparency tools for employers, and not just employers, but other healthcare stakeholders. So specifically, we're talking about the elimination of anti-competitive contracts in language between hospitals and health plans that currently exist. We think that this will greatly help facilitate the purchase of health benefits for employees with a focus on value, and that focus on value will lead to the importance and the critical importance of primary care.
Great, thank you. Regina?
Same question. So my name is Regina Rogoff. I'm the CEO of People's Community Clinic. I feel like I'm sitting in a very oversized chair where my feet don't touch the floor, so forgive me if I'm pushing up a little bit. I feel a little bit like Lily Tomlin, for those of you old enough to remember.
Do you have is it on?
Oh, is the mic not on? People laughed. Is it on? You can hear me? Not on. It's not on. Well, the light is on, so is the volume not? Okay, so I'm not, so I have to, okay. That's what I'm going to do, put it a little higher up. Okay, that better? No, still not better. Do we have it? I can just hold it this way. Now I'm going to blast everybody out of the building. Okay, So we'll see. I feel instead of like Lily Tomlin, like Goldilocks. Yeah, a little too much, a little too little. Do we have it just right?
How about you turn yours off and I'll give you mine?
That doesn't work. Mine is off.
Yeah.
No problem. Now I can hear me. Okay. So if I can hear me, you can hear me. Good. So I'm actually on my second career. My first career was as a lawyer in legal services to the poor. 10 years as a practicing legal aid lawyer. 20 as executive director of the Legal Aid of Central Texas. Early in my career, I was on the board of a little neighborhood clinic called People's Free Clinic, which subsequently became People's Community Clinic. And now I'm the CEO of that organization. And we're no longer a little clinic. We've grown a lot. And I think I can use a little bit of this time to add on to the accolades that others have already given to Elena. Our clinic has been fortunate to have benefited from her vision and wisdom in the role of primary care in the delivery of health care in our state. So what is the through thread between those two careers? It's the needs of people who are low income and uninsured. The clients that I served at Legal Aid are the people that we have as patients at People's Community Clinic. At Legal Aid, I was an early adopter of bringing in social services, a social worker, into the legal aid setting because our patients had need. Now, I fall back into the medical jargon. Our clients, they weren't patients then, had needs for things beyond the legal assistance that our staff was able to provide. Now at People's Community Clinic, what I have tried to do is reciprocate. One of the programs that I'm particularly proud of is one where we have lawyers on our team to provide services. Elena also alluded to that when she was talking about the patient with asthma. Because sometimes what you need is to break a lease or to remind a landlord that there's a warranty of habitability. So I think there is a thread that runs through both of those careers. I will, before I pass the mic, make one comment that it's a lot easier to raise money for medical services for people in need than it is for legal services. So before you start whining or being, self-pitying about how hard it is to do some of these things, it is definitely easier. The public generally understands the importance of medical care more so than they understand the importance of civil legal services. So on that note,
I'm going to let you keep that
Yeah,
mic.
I don't know what I'm going to do with it because anything I do with it seems to be wrong. Okay, that's.
So last but not least, we have Dr. Mark Chassay with Blue Cross Blue Shield of Texas. Mark actually was my former primary care physician, so in the interest of not violating the doctrine of equal risk, I'm going to stop there. But I've known Mark for
I think that's
for
fair.
20 plus years and consider him a dear friend.
Thanks, Tom. Thank you. Good afternoon. Again, I've had a couple of different careers over the last 25 years, but first and foremost, I will say I am a primary care physician. And I got involved with Sue in this organization back where I went in my second career after doing sports medicine for 15 years here in this town of Austin, where I worked for Tom Sees, the Commissioner of Health and Human Services. So it's interesting going from highly performing athletes that really have a lot of resources to basically having the medical directorship underneath the underneath the portfolio as a Health and Human Services executive for the Medicaid office, and to see the whole differences of the diabetes and obesity and what that chronic diseases would at a younger age would end up happening, causing adults to have issues as well. So I got back into sports medicine about 8 years ago. Went back to Houston, did some stuff there. Got back into teaching, back into care. And then I had an opportunity to come to Fort Worth. And there's one person here that I was able to recruit at one of these meetings, Bethlehem Gerard, who actually it's her birthday today, so happy birthday to you. Gratuitously, I have to tell you that. And got to oversee an academic practice plan. And one of the things that I tried to do is inspire some of our younger faculty members there, primary care folks, was let's look at the reason for some of these chronic diseases and disorders. And then, as Tom said, embarked on what, I don't know which fifth career or whatever. For the last year, I've been Chief Medical Officer at Blue Cross Blue Shield. But one of the reasons I took that position was the gentleman that was the new plan president. I told him, I said, look, I want to be able to say after 5 years that our members are healthier after 5 years. And so that's a big statement. I'm hoping I can do that. I've only got 4 more years, folks. But part of that is understanding that primary care is a very important part of that, but also to address some of the main issues that we don't always want to talk about when it comes to chronic disorders. And I might talk about that as we kind of move forward. But I'm very happy to be here. Sue, when I was Deputy Executive Commissioner, we were on the advisory. Then we lost touch a couple of years as I went back into Houston, but we're back, and I'm happy to be back, so I appreciate it.
Great. Well, we're planning on leaving a good amount of time for questions, but I get to ask the first ones. So let's jump right in. So I was reading this morning a really great article in Medical Economics about the journey to value-based care, and the rationale for it, and some of the challenges in really moving into execution. And we also did the Academy did a study or a survey of all of our members on the number of them that are currently in value-based contracts. I think it was about a 50 to 60% response that said that yes, that they were in some level of a value-based arrangement, whether it was Medicare Advantage or shared savings model or participating with an ACO. But only about 10% of their reimbursement was actually tied to value and outcomes. So we got a long way to go. And one of the big challenges that we identified in the survey and that this article also talked about were some of the upfront investments and requirements to be able to succeed in terms of data aggregation, identifying gaps in care, closing those gaps in care. So Regina, I wanted to ask you, where is Peoples in its journey to value, and what have you seen in terms of both the opportunities to participate and provide more comprehensive, continuous care, and what have been some of the challenges that you guys are having to overcome or maybe just completely staying away from?
Okay. My first challenge is making sure the mic's working. Okay, good. So I want to start with a caveat, because I wanted to make sure I said this somewhere in the presentation today. I think we as a community need to be careful that what's going to happen in healthcare doesn't replicate what happened in education, where we look to our public schools to cure all issues in our society. Right now, value-based care, I think, is a brilliant idea, because I think there's nobody who can defend fee-for-service, except for those of us in federally qualified health centers. So that's something that I just want to clarify. Value-based is a great idea when everybody in the community, in the practice, in the clinic, in the community, has access to the basics, and that what you're adding value to is a platform that already provides regular health and health visits and attention to chronic conditions, acute conditions. But you're adding value onto a platform. You're not replacing it with something called value. I think that our society kind of jumps on different bandwagons, and that for a while we thought that the schools were going to cure all the ills in society. We realized that then they couldn't teach. We just have to be careful that in healthcare, curing all the ills of society doesn't end up meaning that there is no basic guaranteed right to health care. As we add on all the things, there are things that I think are important that our society should be providing. Obviously, housing and access to food and water and the basic necessities are things that are absolutely, should be absolutely guaranteed to everybody. So where are we as an organization? So I also like to say that, we were patient-centered before there was a patient-centered medical home authorization. We knew what we were supposed to be doing. We were community-based before there was a community-centered health home, and we got on that bandwagon. And we are value-based, but we don't necessarily have all the tools in place to get reimbursed for that value. I think sometimes the problem is that you're too small, you don't have enough, part of, when I look around, what I see is I see Blue Cross on one hand, and I love Blue Cross, and we do great with Blue Cross, but in Texas, really, the only patients we have who have Medicaid are pediatric patients or pregnant women. That's not where you're going to get your most value. Because what we really mean by value is saving cost, keeping the cost down. Not the cost to the clinics, although sometimes that's the message we hear, is that by way of value they want us to spend less. Really, for us to do what needs to happen to allow the rest of the system to save money, more money needs to be invested in primary care to keep people out of other forms, other systems, whether it's the emergency room or the hospital itself. And that's where I think there's a disconnect. That what we hear is, by way of value, you want us to cut our costs. We're already doing a lot of the things for which we don't get reimbursed. And the reason that we need that pay for performance for the primary care, we call it the prospective payment system. That is what helps allow us to serve the truly, completely uninsured, which in Texas are largely the adult patients, who are the ones who are most complex and who need the most services, for which we are not getting reimbursed at all. So that's my conundrum. I support value. We have an electronic health record. I'm sure that if that we have the beginnings of all the tools that we would need to do that. But I don't think there's enough money in that model, which at least as I understand it to be, to supplant or replace the necessary services that all of our patients should be getting, whether they're insured or uninsured.
Right.
That was the applause line. That was the applause line, folks.
So Chris, and hopefully we can come back and talk about the uninsured and the role that the FQHCs and other community-based entities play in providing that. But Chris, in Texas, and frankly in most of the country, employers play an outsized role in providing healthcare benefits to their employees. I think that Texas has about a 65% of the market that is ERISA, where large employers self-insure and essentially just pay claims. You've got smaller employers like my organization that buy insurance products that are fully insured, but it's still the employer that's helping pay or subsidize the premium for the individuals. So employers have a massive role in the delivery and financing of healthcare and health benefits. So I mentioned this when I opened up. What is driving employers to be more engaged now? Clearly the cost trend is going up and has to play a role, but kind of a corollary, what do you expect your premium dollars to pay for?
Excellent question. Value is the real key here, and value is being understood by employers now in a way that it had not been before. I'll give you an example. Employers had long known or suspected that they needed to support the underpayment to the healthcare delivery system, and I'll refer specifically more to the hospital delivery system. Shortages due to underfunding from Medicaid to Medicare, for the charity that they provide, for the uninsured. There's a new age of transparency underway right now that we think will help change this. A couple examples are, how many are familiar with the RAND hospital price transparency studies? Not a lot, but some. And what this does is it shows the price that employers pay as reference to the same service, same facility, same physician for Medicare. And nationally, that is about 260% of Medicare. In Texas, it's about 257%. There are some who pay considerably less. There are some who pay 400-500% of Medicare. So that was one piece of transparency information. Many of our employers had participated in this, and they were surprised. The other piece that went along with this is an ongoing, and this is all in development, by the way. We're not saying we have all the answers, but we think we have enough information out there to have a seat at the table and try to better understand what's going on. The other is what's known as the National Academy for State Health Policy, NASHP, the hospital cost tool. And what that does is it shows the, based on the information that hospitals are required to submit to Medicare through their Medicare cost reports. It shows their payer mix. It shows their operating profit margin. It shows their profit margin. It shows the relationships of charity. It shows a break-even price as well. In other words, what is, when all the costs are paid by the hospital or the health system, what is the appropriate amount? And by no means are we saying we have the answer for that. But what we do know is that from the employer perspective, employers in aggregate across the state and across the nation are in aggregate paying about 150% more than that break-even point. Well, that's interesting if you compare it to how does it look with Medicaid. When you look, especially in Texas, with the supplemental payments, and again, it's not in aggregate, the rural hospitals really need help. But in the consolidated markets, in which there are a few dominant providers, in large part, they're all making a real nice profit off of Medicaid. They're also making a nice profit off of Medicare, not universally. So it's these types of nuances that are getting employers more engaged. We've been working with our board and other employers to address this, and again, I mentioned the C4, Texas Employers for Affordable Health Care. Employers have not really been in the room at the negotiating table. It's the one service that they provide as part of their supply chain where they're not even in the room because it's done as a collective. Also, we advocate that not one of our employers, and we have large employers in our coalition, Shell, BP, Chevron, Harris County, City of Houston, none of them are dominant enough to be able to go to their plan and request help, to reduce this pricing. It has to be a collective. And I heard Consortium earlier. Collective is the same thing. It has to be a collective effort, and that's what we're trying to do. And I think the time is right. You couple that with the new transparency rules from the Consolidation Appropriations Act. what the hospitals were posting or not posting more often than not. And now the health plans, and the health plans have really taken a great step forward, and the hospitals are coming on board. But we think that this awareness by the employers is what will drive these discussions, and then maybe another follow-up might be, well, what does value look like from the employer purchaser end? But in conclusion, we think that the current model does three things. Number one, it inhibits business growth in the state of Texas, especially for small employers. Our large employers, the big energy companies, these are still probably rounding errors, but not for the county, not for the city, not for our small private employers. It impacts family quality of life, and I could quote study after study after study that shows, because of the higher costs and premiums, deductibles, how that is impacting other areas of their life, purchasing ability, saving for kids' educations, retirement, etc. And the third area is more for the underinsured or those who are impacted and don't have insurance, those critical resources that may be necessary for other important social needs. So,
Thank you. We could probably spend an entire afternoon talking about transparency and cross-subsidization of the healthcare system, but I want to hop over to Mark real quick. So the health plans kind of sit at an interesting crossroads where they contract with employers to provide access to a network to provide health services. They also contract with those that are providing those services. You've heard from the employers about what they want, and I'd like you to kind of share that with us about what are you hearing from employers and what they would like to purchase. And you also hear from the physicians and clinicians out there that are providing the care. Are they prepared now to offer what the employers want to buy?
Yeah, really, we talked about this before about they really want to purchase good health outcomes. I mean, that's really what they want. Mm-hmm. And part of the transparency, just to kind of get back to that, I mean, the gentleman that I work for always says that sunlight's a great disinfectant. And so with this transparency rules, folks are going to be able to see, employers are going to be able to see, oh my goodness, the health system A, I'm paying $600 of Medicare. That's based on what the contract is. We've always said that as folks come together that you do that for value, to increase value. But let's face it, a lot of times it gives you the buying power. And the larger systems are going to have more buying power. The employers are going to want to make sure that MD Anderson is in their network, or maybe one of the top cardiology places. And so when you have to sit and luckily I haven't had to sit in those rooms, but the network people and on our side that have to do that, they have to be able to negotiate all those different things at once. I think the interesting part of the transparency is that a lot of those employers are going to know exactly what the Texas Health Resources Hospital is charging in a rural area, which is, again, some of those areas that just don't get covered very well, period. So I think the transparency part's a huge part of it. They come to us a lot of times with some things that really aren't on the list. It's not necessarily about a medical policy program or a utilization management program. Again, they want great health outcomes, and a lot of this is kind of going towards, what's the best venues of care. We hear a lot about, telehealth, behavioral health, all those types of things, which I feel like is a tool for their own physicians. They're telling us to increase capacity in the behavioral health market. So we're building that. They're like, well, your network market is fine, but our people can't get in. So it's being used. So we're getting the feedback that a lot of their employees are using behavioral health, and it's understandable. I don't think we need to get really into that after being in lockdown, pandemics, all kind of different things that have occurred. So I think those are the things that come to us. A lot of times they'll come to us with ideas that they get from other vendors. We look at those. We try to work with them on what they might want specifically for their population. Sometimes when you're a large payer, you're actually looking at the same thing that the employers are coming at, but because you're larger and you're a matrix organization that might be one of 5 states in a large area, it does take a little bit of time to go through there. So we're very happy to take those types of things back. I think personalized, care, it's not necessarily like a benefit, but I think over time, employers are going to want to be able to give some type of personalized care. And that might not be something that quotes in the medical literature, but that might be something good for their policy. So see those kind of changes that occur. Again, they'd like to have healthier outcomes. We're trying to bring some products that, for example, would help put diabetes in remission through eating and behavioral health issues, maybe reverse diabetes. We talk a little bit, you probably talked about a HEDA score, and this is what I tell people. 10 years ago, a person could have a hemoglobin A1C less than 8, and they were just doing it regular with their diet. 10 years later, they may still have a hemoglobin less than 8. Is that success? I don't know, because 10 years ago, they weren't on any meds. 7 years ago, they're on 2 meds, and it just takes more and more and more to pile up to call it success. I don't know if I would call that success if you're on 8 meds to keep it less than hemoglobin A1C. We need to be able to intervene on some of these chronic issues and push it back. Don't let it go to stage 4. Let's keep it at stage 0 and stage 1. That's just some of my part. And they're like, hey, we love it. We want our people to be healthier. That means that they're going to need less services. And then therefore we will have to spend less. And ultimately we know that if they're spending less on healthcare, hopefully that'll flip back over and their employees will be more beneficial in their pocketbook at the end of the year. Hopefully that was able.
Go ahead,
Yeah.
Regina.
I just want to weigh in quickly because I'm an employer too. FQHC, I have over 300 employees. I want my employees to be able to afford to use our policy.
Mm-hmm.
I think that there's a move afoot where employers are looking at utilization rates and some of the barriers that we or the system has put up in terms of accessing primary care. And I think that there's some more innovation going on in no copay or no deductible for accessing primary care or places that aren't the emergency room to make it more affordable. And that's kind of exciting. Along the same lines, and I'm going to ask both you and Mark, Regina, this question. I think it's about 80% of the total healthcare spend is not attributable to a medical problem. It's a social determinant of health. Yet our fee-for-service system doesn't really recognize those interventions. There are very few codes that you can bill for an office visit for doing an intervention in those areas. Kind of where do you, I understand FQHCs are different in terms of how they get paid because they get paid prospectively, which provides them the flexibility for doing those interventions in a more thoughtful way. So I'd like you to talk about that and how impactful that's been. And then Mark, I want you to tell us where you think the system is moving to allow more community-based doctors to be able to perform like FQHCs. Is the reimbursement model changing? How far away are we from that? What are some of the plans or ideas that Blue Cross is looking at?
On? Yes.
Yep.
So I'm going to disagree with you just a little bit. I don't think that the PPS rate helps pay for those interventions. The PPS rate helps us pay for the uninsured to get the basic care. The wraparound kinds of interventions that we are able to provide come from places like Episcopal. They don't and they shouldn't pay for things indefinitely. That's not the role of foundations. At Peoples, we're fortunate that we have a strong network of donors, but they pay a very small percentage of what our costs are. So to be able to do those services, there has to be some solution I don't know if it's this guy over here. I really don't know, which is why I say at the outset that these are, I, by the way, think that calling it social determinants of health is a misnomer. They are certainly determinants of health, but I think we should either call them societal or political, because we have made choices in a society not to have adequate housing, not to make sure that the basic need for food and water and air are all accounted for, that we don't guarantee quality education. There are so many things, almost everything that we look at in terms of social determinants are political decisions. And social is like a euphemism, so nobody is responsible for them because nobody is, it doesn't identify who's responsible. So I think that's one of the important things to take away from this, because right now the PPS rate isn't intended to and doesn't, and particularly in a state that hasn't expanded Medicaid. A third of my patients don't have health coverage. In Travis County, the ones who live here are fortunate to have the healthcare district pay for, it's not really insurance, pay for individual instances of medical care. But that's not a plan, it's a strategy. And in the long term, there's got to be some better solutions. So I'm going to turn it over to you.
Well, thank you. So one of the things I learned in Austin was about the air quality and all the allergens in the air. And one of the things that I would do, even though it was not on the plan as a primary care doctor, is that I actually recommended air purifiers for people that were continuously having problems. Like, you're going to be in the same room sleeping for 8 hours. Let's try to at least get this clear. And I would write them a prescription. I said, this is the best I can do for you based on probably what your benefits are and your plans are. But you don't have to pay taxes on that air purifier and the filters that I'm writing down, so that you can do that. Previous institution, some of the folks that were working in what we call our Safer Care Texas area kept saying, all these folks, when the freeway starts getting built, coming down, whatever, it's gonna be 35, 45, we see more asthma in those zip codes. Same thing, can I go and buy a bunch of air purifiers at least for 8 hours a day? I mean, it's probably makes a lot more sense than folks going and even setting foot into the emergency room. It's those types of trade-offs that are gonna be really important kind of moving forward. And part of that is I go back to the vendors. We've got some vendors that will sit for folks. They will, especially in the Medicaid spaces. We're looking to be more of a player in Medicaid, by the way, because we have not been a big player since 10 years ago when the 1115 waiver came out. And there's probably other reasons for that, but there's a big commitment for that. And so we've been working on some RFPs, one for the Star Plus population, and then later on in the next couple of months, we're seeing what probably be dropped for kind of the larger Star chip. And as part of that, even though I'm our commercial side CMO, I really got to meet a lot of the vendors that do these types of things, where they can show what the benefit is for having a sitter and doing this, or to get someone this air purifier, or to make sure they're getting the right food. And they can show that. They've been working on it, showing those cost benefits. It's very helpful to have those, to be able to make the statement, to engage that provider, to bring that to even folks that might have dependents that have these issues on the commercial side or even on the Medicare side. So I think you're seeing a little bit of a buildup of folks being able to take a look at those and coming back to us and say, hey, these are some benefits for this type of the population, and we can show this much of a savings. And of course, that's great. That's good quality of care if they're keeping them out of the emergency room, or it helps them with their behavioral health, and then you're not getting a emergency room visit from that standpoint. So I think there's kind of a buildup on that. Now, that kind of comes into the whole umbrella of the ACO and quality over cost and our value. We feel like it's an important part of the value. Most of our ACOs are primary care based right now. We probably have about 30 ACOs that are that way with Blue Cross Blue Shield. There are probably about a half of our 6.7 million folks are probably in these types of arrangements, and almost 90+% of primary care are in some of these arrangements. So, but we're still behind on that. New President Jim Springfield really wants to push that. There's a lot of folks on the PPO. We talked a little bit about this before. You know, in some regards, my president feels like the PPO is, you got your Disneyland card to get on the front line for everything, and you run around, it's the most expensive thing that you can do, right? I do too. I have the same PPO. So whenever there's a little bit more, and there's some of the ACOs, we'd like to push employers with great products in the ACO market so that they can see that decrease in spend and the increase in the health outcomes. But again, you know, we might have some differences on that. The HR person at those larger places, this is a big responsibility when they put an RFP out for a Blue Cross Blue Shield or United Healthcare or Humana or Cigna. And sometimes you'll have you'll have apples and oranges, and you'll have everything that's kind of looked up, and they're trying to see what would be the disruption that we would want, or what's the disruption that we don't want with our members. And I think as you see some of that, sometimes with all things maybe being equal in their mind, they might do a little bit less disruption because they don't necessarily, there's some things we'd like to do with some other folks and with Rice and health economics in regards to taking a look at what are the surveys, you know, what are they open to? Is 50% of them very interested in a very narrow network and they're happy to do that? Is the other part, and kind of tier that to what they need instead of just a broad approach for insurance for a large corporation.
I was actually just about to ask Chris that question, but
I teed it up for you.
Yeah, you did perfectly. But the kind of going back to your asthma story, it reminds me of a story I heard about a patient that was, you know, hitting the emergency room about every 3 weeks. They couldn't figure out why. The cost or the spend for that patient was significant. Diabetic patient. They finally went and did a house visit, figured out that the patient didn't have a refrigerator, couldn't store their insulin. So, you know, the plan bought that patient a refrigerator to store their insulin, never went back to the emergency room. You know, and you know, got their hemoglobin A1C down and managed. But again, our current system really doesn't allow that flexibility because it's not a billable event for a refrigerator. So thinking about those sorts of benefit designs, or more importantly, to the question I'm going to ask Chris, you know, employers, especially self-insured employers, have a ton of flexibility in terms of how they design their benefit package. Traditionally or historically, employers have been hesitant to limit network participation or to curate high-performing networks because by definition you're going to leave somebody out. And you're going to limit patient choice. They can't go to whatever buffet line they want and eat out of the trough. Are employers changing their perspective on that, or why haven't they if they've not?
Great question. I've got a couple thoughts here. I want to make sure I address them. First of all, healthcare is considered an overhead expense. But it's an overhead expense that, without doubt, has more than anything else contributed to the lack of wage increase in employers over the last 2 decades. And part of that is because of lack of ownership by the employer. To me, this is a critical part of the supply chain. I often hear, well, healthcare is not our primary business. I work for large energy companies. Pipes were not their primary business, but I guarantee they knew everything about quality and everything about pricing when it came to pipes because they had people in their own house that knew this. And right now, most employers don't have that. The largest employers in the country have minimal expertise in healthcare financing and how the whole system how the whole systems work. And part of that is because of this perceived complexity. That's a new word. Perceived and actual complexity. And it is. And that's by design, by the way. It doesn't have to be that complex. I listened to several different podcasts. Relentless Health Value, if you haven't heard of that one, is an excellent podcast. Stacy Richter is the host on that. And she does a great job of talking about everything from contracts. You don't need, for 1,000 clients, you don't need 1,000 contracts. You need one contract with a few variables. It's made complex by design. Again, I mentioned it's not their core business. I think I answered that. But it's really not owned by most organizations at the level where it needs to be, and that's at the C-suite. This is given to benefit managers in the HR group who, again, don't have that expertise, so they rely on the advice of their intermediaries, in particular, their benefits consultants. There's a lot of misaligned incentives in this business for promoting one plan over another. I think that's part of it. I would ask, and I've talked about this before, because of the answers I've gotten when employers have asked for a seat at the table, it makes me wonder, who is the primary client of the health plan? Is it the employer, or is it the hospital industry? I would ask the same thing of the consultant. Is it the employer, or is it the health plan? And I'm not saying what it is, and it's not universal. I just think we have to understand who the primary client is, and I think that leads to a lot of answers. I've mentioned before that employers have not had a direct seat at the table. It was designed that way. I think it would be helpful if for instance, collectively, that when Blue Cross Blue Shield negotiates with Houston Methodist, if you had a half a dozen employers in there who now have this knowledge and understand how the sausage is made. That doesn't happen now. And I think what's going to change this is the new age of transparency. I truly, truly believe this. And you can see it by what we're trying to put together in the Houston market and hopefully throughout the state. We call it a smart network. The smart network has, first and foremost, advanced primary care as the foundation. I won't say we're agnostic about the primary care group, but we want all to the table so long as, number one, it's not a fee-for-service model, it's capitated. Number two, we have a sense of a standard agreement on population health outcome metrics at the population level, not at the individual level. Number three, that it's integrated with behavioral health. We have such a crisis there, and this helps solve for that. There's a lot that can be done with the collaborative care model in behavioral health. And then last, but certainly not least, the largest expense for any employer is hospital services. We'd like to see a doubling of the expense in primary care. We think through the better management of chronic diseases, this will help in that capitated model, if you will. And number two, that right there at the point of service, that trusted relationship between the primary care physician and their patient, when they do need a specialist, they can refer to that person based on the best quality, and that means perhaps tiered networks. Right now, you can't have tiered networks because of the way the contracts are written. And number two, on pricing, we think a reference to Medicare in some way is a way to go. And we'd love to work with the plans on this. I've mentioned that to Mark and others. But if that doesn't work, I think the hospitals are, because of this, are getting ready to do a little bit more direct contracting.
Right. Well, let me ask one. Go ahead, Regina.
Just as a follow-up to that comment, I thought it was very interesting. I don't think I think in terms of the employer's interests as much as I should, even being an employer. But what I didn't hear in what you said, who are the clients of the insurance company? Is it the employer or the hospital? I didn't hear mention of the patient.
Bingo.
And likewise,
point.
when you said who are the clients of the hospital and the providers, you didn't.
It's an excellent point. It's an excellent point.
Okay.
Yeah, I think that that's an unfortunate function of a third-party driven
Excellent
system.
point.
So let me stop there and see if there's any questions before I continue. I'm giving you an opportunity. The mics are on in the front if anybody would like to ask any of these incredibly thoughtful folks a question. Or I guess dessert. Yes, Sue.
I'll ask a question. It's really kind of directed at Mark Chassay. So talk about primary care referrals to specialists. And I think one of the biggest challenges in the primary care world is knowing your specialist. And by that I mean, I don't mean that you play golf with him or her, but I mean that you or go to church with them. That's great. But what's their utilization, right? What are their outcomes? How are they kind of on the bell curve in terms of, and how responsive are they to you? And that's maybe a difference. But I think one of the things that is really handicaps primary care practices from referring appropriately is just that. It's the lack of available data. Even in some, sort of closed systems, I think that's hard to do. And I think it really handicaps primary care physicians and their ability to be good stewards of healthcare.
And I would agree. Tom and I have had many discussions about the information that a carrier can give back to the primary care folks in regards to the quality, those types of things. There's some public data, but it might be for it's kind of an aggregate, or you might be able to find something on the Medicare about a surgeon that's across the street that maybe you do go to church with, or you do have lunch with, that you can kind of see, but it's not the same in regards to what they're doing with in the commercial market. And there are some rules in regards to what the payer could do contractually, and I think regulatory. We've discussed that a little bit, but I do think it's important to, if I can't give you the numbers per se, that I can find some way to, qualitate it with some stars. Like here's the 3 stars from this person, or a 2 or a 1. So it gives you a little bit of idea what the quality measures might be, and we might list what those quality measures are, and then you get to make that decision if that's important to you and your referral source. But
In Dallas, I know the late Don Reed, the colorectal surgeon, started at Aspen.
Yeah,
Mhm.
Dr. Schneider as well.
Colorectal surgeons is a big group, he has a big group, and they started collecting their own quality data and utilization and cost data, and that's very powerful. And now the cardiologists are doing it some, and so, which to me reflects the fact that others are not as able to do it. I understand that there's different.
Well, they could. I mean, if we're taken out of the middle part, if like a Dr. Schneider and Aspen or whatever the next iteration of all that wants to go to a primary care book and says, here it is right here. Here's all the data. We want to be your primary client in regards to referrals, and here's the book, and this is where we're at. That's helpful. That's part of breaking the cycle and the sharing of the data.
I think what you're likely going to see going forward as more groups move into risk-based contracts, in order to manage that risk, they're going to have the data to appropriately refer to either the specialist, the facility, the imaging center, and looking at readmission rates. Again, that's not readily available. Some of that was because of the changes we put into the HMO Act back in the mid-90s or early 90s when all the IPAs in Texas collapsed because they didn't know how to manage their risk. I think that the technology that exists today, the transparency that is coming, is going to help expedite that. But we're not there yet, and part of the reason is because we don't have a payment methodology that most plans can administer to delegate that risk. So a great question just popped up on the screen. I'm going to read it so everybody can, I didn't realize it was up there. So it's a great question about how do you advocate for improving outcomes, increasing primary care spend. And I'm going to start because there are a number of states that have begun passing laws mandating a certain percentage of primary care spend or increased primary care spend. Additionally, we've got passed an all-payer claims database bill that's going to allow us to independently determine or see how much we're actually spending in primary care in Texas and be able to turn the levers on that to put more money in. I think the challenge is at a state level, or at least a legislative level, our budget cycle is every 2 years. It's really hard to look long-term or do longer-term investments if you're not going to see the return on that investment until year 5. You know, if you're in Medicare, you're in a single-payer system. I mean, you're in Medicare, and they will see the long-term returns on that. If you're like me in a commercial market, I may be in Aetna 1 year, Blue Cross the next, Humana the following year, and you know, then direct contracting with somebody. Yeah. So for the plans to capture that value with their investment, it's going to be returned to somebody else. So with that, feel free to jump in.
Well, I've talked before that it is an investment. I think we've got the numbers that show that, you know, people live longer and healthier if they have a primary care doctor. I don't think anybody here would deny that. I think that we talk about the investment, and it's a big sea change when it comes to us moving this forward. And an employer looks at a 12-month budget. A payer looks at a 12-month budget. I mean, everyone looks at a 12-month budget, and this is not a 12-month, there's no way we can get this done in 12 months. It has to be 36 plus more. It has to be an investment down at the bottom with everybody doing an educational collaborative at the beginning and then seeing where it is at the beginning. I think my plan president really would like to open up the cap so that primary care, it's not just primary care, because we can only do so much with the primary care. We have to have the specialists that are on board and understand that. We need to work, really for the most part, we like to say, we all want to work smarter and not as hard. And there are lots of folks that can help in your office if you're doing this right, that can help make that call to the 80-year-old female that just, you know, came back home with congestive heart failure. There's lots of folks that can do that. That doesn't get paid, but as you kind of go through these different models of care where you get paid more per member per month for all these types of things, that's an important part. So, you know, from that standpoint, I feel like it's this exchange of data within those specialists that are like-minded, that would like to be with those primary care doctors and understand that they don't want to have to keep hiring expensive specialists in their practice. They like to keep their practice the same, work a little bit less, and kind of share the benefits.
Or you delegate that responsibility to the primary care doctor to curate the referral network. I would imagine that if a large group of primary care doctors came together and went to a certain hospital, high-cost hospital, and said, we're not going to refer any more patients here, that they may have a different reaction than Blue Cross saying, you know, let's negotiate a network deal.
Sure.
Right.
Agree. Different ways to hit it.
Mark, I would agree with you. It is an investment, and that's one of the messages we're giving to our employers. I talked about the smart network. This does not come at no cost. It has to be an investment, but the rewards will be reaped. The good thing is, though, there are plenty of stories, at least nationally, that show how well this worked. The best one that I can cite, or a couple, are the Intermountain system. I've had an opportunity to work with Dr. Brent James, who's now at Stanford, looking at clinical excellence. That's one, and of course the Kaiser Permanente model. I mean, it works. We just haven't put it in Texas yet, and I think we're ready for it.
Dan, go ahead.
Yeah, the TPCC came together to really promote PCMH throughout the state of Texas, and we now know that clinical entities can get PCMH recognition. Some of them, though, really is just checking off the boxes. There hasn't been the culture change that comes with what is necessary to really do that. We don't have a good marker for the sort of thing we've heard this morning for an FQHC who has care coordination, population health, integrated health care, and really are doing systemic changes to affect outcomes. We need a new marker, and I'm wondering what your thoughts are about that. Is some sort of recognition that, and I don't know if maybe once we get the all-payer claims database, if we can then segment primary care providers based on how much they do that. But I just wanted to throw that out.
That's not the question I want to answer. Can I be a politician and just answer the one that I want, and then we'll see if that segues into your, see, that was full disclosure and transparency. It's really frustrating to me because yesterday you were the pessimist, and today maybe I'm feeling like the pessimist. Somebody said to me recently that change is possible in Texas. We just have to change the legislature first. And so, I mean, when we're in a political environment where there is little to no interest in investing in anything other than tax cuts, I think it's really hard to do any of the things we're talking about. I think that one thing to keep in mind is that everybody fights when they're going to lose something. So making these changes, if Regina ran the world, what we would be doing is increasing benefits to providers or that are doing certain things before we started cutting from the hospitals or from other parts of the system, the specialists. Because if you start seeing the changes, if you make the cuts before the changes have had a chance to take effect, it looks like you've distorted the system, like you're running a scam of some sort, that you're not being fair. And you also generate more hostility and more enemies and more opponents. And you start off in the state with a lot of people against any changes already. So I think that it really behooves us to think in terms of rewards for those who are making the changes, whether it's PCMH, finding ways, or anything else, finding ways to recognize those things and encourage them, not to punish some other part of the system. If what we're doing is actually going to be successful, those successes will show up over the next couple of years. And then you'll start seeing fewer people going to the emergency rooms, fewer people needing specialist care. And then you can say, well, we have fewer people needing these services, we can start looking to cut them. And then you have your case, you have your data. Just one person's thoughts.
All right, we got another question from Dr. Jackson. Is our healthcare system getting better, worse, or staying the same? Chris.
Wow.
Come on, this is rapid fire.
It's staying the same with hope for change. I haven't seen it yet.
Getting worse. Because I think the costs of care, the costs of everything, and this is, the COVID crisis, whatever we're going to call it. There's got to be somebody who does marketing here who's got a good, quick name. It's COVID something. But one of our sessions was about creative ways to keep staff or get staff. I mean, I don't know, everybody in the room who's having difficulty filling positions, raise your hand. I mean, there are some of you who aren't? Okay, I don't believe that. Right now, the cost of delivering the service is ramping up more rapidly than any solution to fixing it.
Mark?
Well, if you're measuring it by cost, I mean, we're getting worse.
Yeah.
If you're measuring it by actually the health of our population, we're getting worse. Yeah. And I'm not saying it's cause and correlation, but we've got a sicker population and we've got more cost. And I don't know how I don't know how you change one for the other. I suspect if you get a more healthy population, costs better go down. or somebody's got some explaining to do.
You know, there was another old country doctor, it was not Dr. Curran, that told me something that's stuck with me since I started at the academy. He said, patients want three things. They can only have two. They want the best, they want it now, and they want it cheap. And that from an economic standpoint, that's impossible. And I don't think as a society we have grappled with the trade-offs of those questions. And you know, in a political environment, I don't think that we're going to be tackling those issues anytime soon. So, yes.
Thank you. So I just want to say thank you to the panel and thank you to the summit. I guess I'm going to be the feathered one today after the Emily Dickinson poem yesterday. I have been inspired by the quotes and the poems that we share here, and what I'm hearing the theme is that it's a longer runway than we allow ourselves. And so we also hear about the power of legislatures changing their minds when they had stories. And so we all have stories. We all work with people who have stories, and never before has the communication been more connected. And so when I started my improvement career a couple decades ago under the Daughters of Charity, they worked for the long run, right? They were going to do it and as long as they were breathing, and I've been inspired by that. One of the quotes that struck me 20 years ago, I think is really valuable now. It was about wellness programs, and the HR people were saying, well, what if we invest in them and they leave? And the real answer is, what if you don't and they stay? And so we're talking about this benefit of these plans, and then someone else is going to reap the benefits. But if everybody was investing, then the movement of people across employers, you'd still reap the benefit from someone else's investment. So I just am grateful to all of you and the work that you do, and for all of us trying to continue to focus on health and care. So thank you.
Thank you, Bethany.
I think that is
I
an
got to work with
excellent,
her for a year.
excellent
I'll let
way
you
to,
resign.
I have to.
An old
defer.
country doctor will ask you a question. It really bothers me. We very seldom have conversations about healthcare. It's almost like religion and other issues. You just don't talk about that. I mean, and the conversation usually begins with, well, healthcare is really complicated. So it's just really complicated. So we can't talk about it. How do we begin a conversation that's realistic about healthcare with the average Joe? Because I don't think anything's going to change until the average Joe on the street gets the idea that I'm getting screwed from the healthcare system, and I got to figure out a way to make it different and make it better. So how can we get it down there so that we can get some of those things done? What do we do with we advertise. I mean, Blue Cross advertises. I even did a commercial for them, and all kinds of stuff. But how do we do that? How do we get to that individual that really, healthcare is about you. You ought to demand some things from that. You ought to realize what it costs. You ought to know. You know that they got about 15% profit in that car when you go to buy it. It's probably more like 20 now because they don't have very many. But all those things, we ought to know some of that. What can we do to get that done?
I'll take a quick crack at it, and I think it starts with the word trust. I had there's a lack of trust between the parties. The health plans don't trust the hospitals don't trust the health plans, the employers don't trust the employees don't trust the employer. I think it begins with trust and perhaps health literacy. This is not something that I think starts when you're 50 years old. I think if we had more, it's like we can add another thing to the educational system, but we're so health illiterate in this country, both in terms of cost, in terms of disease states. I think that is an excellent point. I don't have an answer for it, but health literacy is, we are not a health literate country. Don't have an immediate answer for that.
I would just jump in, and when you talk about trust, family doctors, I mean, I mean, most of these people in here are willing to have that conversation and find out what's, again, there's gonna be probably three things. You gotta figure out the 2 and the 3, and on Monday, those 2 might be different than the next day. That's the unique part about every single person that comes into a primary care doctor's office. The person next door might not have the same 2 as the same person that comes in and then the next week. So it's constantly changing, but I think the more times that you talk to them about that, then they get to make that decision. They get to make the decision on what the trade-off is, and they can they can make some, they might not be happy, but at least they're educated, and that they might decide that maybe a different employer has the types of benefits and the understanding that they would want, or maybe they're just gonna go and get insurance, maybe what we call the individual and family market, because they don't agree with what the employer's doing. So it's trust with primary care.
One of my favorite movies, actually it's probably my favorite movie, is called The Fog of War. It's a biography of McNamara and what he learned in his time as the Department of Defense head. And through the Vietnam War and other things. It's amazing. And he's got 10 lessons, and one of them is sometimes seeing and believing is both wrong. And I think that we come in with perspectives or beliefs that we need to be challenged on. I don't believe that trust is a huge issue. But I think the relationships that we have with the business community, with the health plans, it functions like this, where we can sit down and agree to disagree respectfully, or agree to agree. Maybe not on the final outcome, but know something needs to be fixed. I think more of these types of discussions collaboratively, where you've got parties that are presumed to be on the other side of the table, you might find a lot of common ground. And that makes a path forward a lot easier. So with that, I'm going to conclude this panel and turn it over to Dr. Bornstein.
For the first time in a long time. What we plan to do is to keep doing what we're doing. We're doing more. One of the things that we're working hard on is our consensus panel. We have a group of experts, a couple of them were up on the dais right now, that we're helping to craft some policies that we want to take to the Texas legislature in the upcoming session in 2023. And that's a little bit of a change for us, but we realize that it's really not enough to talk. It's great to talk about things, but we really need to put that talk into action. And so hopefully in the next few months, you'll see some concrete proposals that we are bringing forward. We have a great group of people like Chris, people like Helen Davis, people like Tom, a lot of different folks from different parts of the healthcare world that we haven't really collaborated with before, that are now engaged in this work. And so that's good. So anytime we get new engagement, we like that. So we want to continue to be really your trusted source. We're the neutral convener, and we love to bring people together like we have today, and the last couple of days, and share and really rejoice and to appreciate what you do. There was a fair amount of doom and gloom, even though Tom, I think, took his medicine today and was feeling more positive. Joking. But to me, the underlying thread is there is hope. There is always hope. And there's hope, and it takes time. And so I think if we have the appropriate sort of mental and emotional timeline, we will get there. And we will get there really because of you all. So on behalf of the Texas Primary Care Consortium, Do I have a slide of our team? We really need a slide over there. Okay, well, there's not pictures, but Ankit Sangwi, our Texas Health Institute CEO, unfortunately could not be here. Nishi, raise your hand. Nishi, you're right there. Stephanie Andres, who really is the heart and soul of this, if I can say. This is the 10th year that Stephanie and I have done this together. And so, I can't, she hates to be, called out, but I cannot say enough about how great it is to work with you, and I love you. What can I say? I do. Katie Bradley, where's the wizard? Where's? Wizard, present yourself. The wizard. We call Katie the wizard because, well, she just is. I mean, if you knew her, you would know that Katie is a wizard. All of us can make things happen. Kanika, who was out there doing the interviews. Kanika is a relatively new addition to our team, Director of Communications, and Megan Varghese, also Director of in the Communications, and Lisa Smith, and lots of other people. There's John. There's a lot of other folks. So I feel like a part of the THI family, and it's a wonderful family to be a part of. So again, thank you all. Thanks for your hard work. You make it look easy. And we really appreciate it. I wish everybody safe travels, stay safe, stay well, and we will see you next time. Thank you.